Okay, so welcome, good afternoon everyone. Welcome to this training session run on behalf of the Department of Communities and Justice. And the purpose of this session is looking at the sector support that DCJ are providing for DCJ providers who are preparing your COVID-19 management plans. And this session, we brought together in particular providers from homelessness services, so particularly specialist homeless services, domestic and family violence, residential services, and youth and other homelessness services. So welcome everyone, great to see you all and looking forward to hearing your questions and comments. Through the 90-minute session today, we've got plenty of opportunity for lots of open questions. We've also got a chat function, which you can jump onto with any questions as we go. Now, before we start the session today, I'd like to acknowledge the traditional custodians of the lands that we're meeting on today across predominantly New South Wales, but other parts of Australia as well, and pay our respects to elders past, present and emerging, and also pay our respects to any Aboriginal and Torres Strait Islander people joining us today, and indeed all Aboriginal and Torres Strait Islander people living in the communities that we serve in the work that's done across New South Wales. And also just note, acknowledging as we're talking about, COVID-19 and how to mitigate some of the risks of COVID-19 today, that clearly that gap in vaccination rates between COVID-19 in Aboriginal Torres Strait Islander communities and other communities is quite pronounced. With borders starting to open up around the country, we are now starting to see that creeping in. So the timing of the session today is quite prescient, really. Okay, Anna, so just a couple of quick housekeeping things. As I mentioned just before, we always find it great if people can turn their cameras on. So it's really nice to see your faces and get a bit of feedback. We ask people to stay on mute generally, but at any point, feel free to just come off mute and ask a question. So we have got, so I can see somebody's struggling to hear me. Just checking. Anna, can you hear me okay? A thumbs up. Yep. So Gabrielle, I might get Anna to just pick up with you to see if you can sort. Yeah, I think Anna will try and help you out with some of the technical problems. And yeah, I encourage you to just turn your mobile phones on silent throughout as well. So if we move on to the next slide. As I mentioned previously, we have a chat function. So we're monitoring the chat function. There's already quite a lot of activity on it. And we're actually not going to use breakout rooms today. We're going to just have group discussions through the forum. So do feel free to just speak up and ask your questions as we get to those points. And we've got a range of people on the call today to answer your questions throughout the session. So I'll come on to introductions in a moment and talk you through who we've got. So in a minute, we'll do some introductions. Mika from the REVEC team and Alice from Justice Connect will help us talk through the overview of the guidance. And then we're going to have three, facilitated discussions throughout the main part of the session, where we can try and tease out some of the key issues that you've been facing around some of the key COVID-19 risks, what some of the most effective controls that you've been putting in place. So I guess the style of this session we've recognised is because the guidance was published on Friday, we are presenting today, the key aspects of the guidance, but really wanted to have plenty of time during the session for questions and discussions, so it's as interactive as possible, rather than making it too didactic from our side. Okay, so if we move on to introductions, and so I'll just quickly introduce myself. So my name's Jay Rebeck. So I run an international healthcare consultancy called Rebeck. We are based in Sydney. We're a team of seven consultants for the core team, with a total team of 20. And we've been providing support to DCJ for around 3 years on a range of different projects, but most recently, the last 2 years, providing support to support DCJ and the providers in DCJ with COVID management plan support to really help mitigate the key risks emerging from COVID-19, which is, of course, what today is all about. So I am fortunate enough today to be joined by Anna from our team. So Anna, I think if you wave now. So if anyone's got any technical problems today, Anna's working her magic in the background to try and sort that out. And then Mika, who'll be co-presenting with me in a minute, he's just waving a hand there. So I'll next up, I'll ask Sophie if you could introduce yourself and some of the other team from DCJ. That'll be fantastic.
Hi, yeah, I'm here. Thanks, Jay.
Thanks, Sophie.
Sophie Holloway, I'm the Director of Policy and Programs. I work in partnerships, and we've been our team's been working on the work related to COVID management plans and the like, and also engaging Rebecca and Justice Connect and working with PEAKS very closely on these seminars and supports. I'm joined, so I'd like to, I guess it's fantastic that everyone's come along today. We've got a lot of people here. I see there's 63. Really looking forward to the discussion and hearing from you. I'm joined today by members of my team in commissioning policy, Michelle Dowd and Shay Baxman. Michelle, I don't know whether you wanted to sort of say anything. They're from our team, have been supporting this work. And also from DCJ, we have from the Family Preservation Program, Cassandra Canitz. We've got Deanne Smith from the Homelessness area and Inara Walden from Victim Support in Strategy, Policy and Commissioning. So they're all our team members today who will also be popping up and providing some insight and advice as needed. And that's it from me, unless Michelle, you wanted to say something.
I think you've covered it nicely, Sophie, but hello everyone, welcome. It's great to see so many people online. Hope you get a lot out of it.
Lovely. Thanks, Sophie. Thanks, Michelle. And yeah, great to have Shay, Cassandra, Deanne and Inara with us today as well. And Alice, if I could just get you to introduce yourself as well, that'd be fantastic.
Sure. Thanks, Jay, and hello, everybody. So my name's Alice. I am a lawyer at Justice Connect. For anyone that hasn't used our service before, we are a registered charity and an accredited community legal centre. And I work in the not-for-profit law program, where we provide free legal help to not-for-profit community organisations. So not-for-profit law in our team has been providing a range of different supports to community organisations in relation to COVID-19 issues in the workplace, including vaccination issues. So we've been invited to come along today to basically answer any legal questions that pop up during the session, whether that be about implementing your COVID management plan or any adjacent issues that come up around privacy or workplace issues or anti-discrimination. So in answering your questions, I will be giving legal information rather than tailored legal advice for your situation, but we'll be providing you with lots of helpful resources and links to further information, and I'll also let you know later on how you can actually come to Justice Connect and get some free tailored legal advice as well. So that's me. Lovely to be here, and look forward to some good discussions.
Fantastic. Thank you for that, Alice. And yeah, great to have you here and to have your that legal perspective. Thank you, Anna. So in terms of the overall purpose of the session today, and the reason that we've developed this guidance is to help equip you as providers providing services that are commissioned by DCJ with the support that gives you the tools to develop a robust COVID-19 management plan. Now, one of the key things, I'll say this a couple of times today, is that the COVID-19 management plan is not an entity in itself. It's actually made up of 3 constituent parts. So there is no template for a COVID management plan, but the 3 constituent parts are, firstly, is the COVID safe plan, so from Service New South Wales. The second is a risk assessment. So as you'll have seen from the guidance on Friday, or if not, in fact, Anna will put that into the chat just in the next few minutes. We have given quite a lot of guidance about how to develop a risk assessment because of having listened to the sector. That was the feedback that we were getting, was that was where most guidance was being sought. So that's the second part of the COVID-19 management plan. And the third part is a business continuity plan. And we haven't specified a particular format for a business continuity plan, but what we have done in the guidance is pointed to the New South Wales small business continuity guidance, which is a useful template. And again, this is a key message for today, is if you've already developed these plans, you don't need to develop them again. So the aim of this guidance that we've submitted on Friday isn't for you to all go out and have to copy and paste, work from an existing plan into another template. That's not the case. If you've got your plans in place, that's fine. It's what we heard from more than 350 providers in the survey was that there was a request for a bit of support about how to develop good guidance. And so that's the purpose of this guidance. So for some of you, if you haven't had a chance to develop some of these things, it may be that you're developing them from scratch, in which case, fine. We've got great, really good, well-structured approaches that you can use. For others, you might find some of the techniques that we use here helpful when if you're refreshing your plans. And there may be others of you that have actually, you feel very comfortable that you've got all this in place. But in any case, the aim and the request from DCJ is that you're able to show that these three components are all in place by the 22nd of December 2021. But as I say, you may already have this in place. And we've been through quite an extensive consultation process with all of the peaks across DCJ to develop this. And so the guidance is a synthesis of that guidance, as well as input from our public health experts to make sure that it's as fresh, up to date, and practically useful as it can be. So the objectives of today's session, in light of that overall context, then, is to explain how the guidance can be used. So we're going to the first sort of 15, 20 minutes, we're just going to step through how this guidance is structured, how it works. And then we're going to have a series of facilitated discussions with everyone. So we'll have plenty of opportunity to provide some feedback about some of the controls you've already been putting in place. And to have a bit of some real life sharing of examples in real time. And so we've done this as the third session we've run now, and we found that to be very helpful, sort of shared learning. So that'll also give a bit of an interactive forum. And I've just muted, there's just a couple of people there who get a bit of feedback, so I've just muted you. Okay, so Mika, if we just move on, I'm going to hand over to Mika, actually, who's driving the slides today. He's going to just talk us through a bit of an overview of the guidance and how it all fits together.
Hello. Yes, so I'll just run us through some of the guidance. So this slide shows us some of the things that are in scope for the guidance document. So to begin with, this guidance, it does apply to service providers regarding services contracted by DCJ, and as is also reflected in the policy, it does not apply to people who just receive the grants from DCJ to provide their services. As Jay has mentioned, this guidance provides you with some templates around the management plan. So that includes the templates for the risk assessment. So that's been put up on the DCJ website. There are also other examples of templates, as Jay mentioned again, from the business continuity plan, and also some examples that have been provided by other providers who have already completed theirs. And this guidance, it does not require, and the policy does not require DCJ providers to complete new plans if you've already got them in place. So really the point of this all is to make sure that you've got something up to date, that's relevant, that is consistent with the current legislation and with the way that your business is interacting with the community in the COVID situation. And finally, this guidance does provide considerations for common legal questions. And as Alice said, she's on the call today to try and answer some of your questions, but the guidance does not provide specific legal advice due to the fact that obviously each provider is different. The people they're providing their services to is different. The way that it's done is different. So you might need to contact Justice Connect to speak to them on a one-to-one basis to get answers for your specific questions. So on the next slide, this is the structure of the guidance document itself. So as Jay said, that was put online on Friday. So the first, the chapter 2 shows you what is involved in the COVID-19 management plan. So that is those 3 pieces: the COVID-19 safety plan, the risk assessment, and the business continuity plan. And so the way we've structured this guidance is to have that information right up the front, so you can have a look at that, understand what is required of you, see if you've already ticked those boxes, see if there are any things that you need to add into your existing plans, or if you need to start a new plan. And then we've got in chapters 3, 4, and 5 some information or considerations for workers, clients, and operating environments. And as I mentioned, obviously each provider will have different combinations of people who they provide to, the workers that are involved, and how they provide these different services. So in the guidance, we've thought about some of the ways that different workers or clients or operating environments might have an impact on the actual risks that you might encounter, and how you can therefore amend the controls that are involved. So for example, if you think about the workers that you might have, there could be employees, there could be contractors, there could be volunteers, and the way that you adapt controls is dependent on that. If you think about clients, you might have some clients who live in a remote area or who are from a lower socioeconomic status. And then in addition to that, you think of those client groups, people who are experiencing homeless, people with disabilities, and how all of those things interact to, again, adjust the way you put controls in for these different risks. And then finally, the operating environments, considerations about if you've got a face-to-face way that you provide services, whether that's in your own premises, so you have control over the environment, if it's in external premises where you don't have so much control, or other examples would be in a residential setting, home visits, or in a residential facility. So those are the 3 sort of main things that feed into your considerations of how to develop your COVID-19 management plan. I think, Jay, you may want to speak to this next.
Yeah. So I'll just talk through some of the legal requirements. So I think one of the key points about what DCJ are asking of providers is that actually what's being asked is essentially adherence to existing legal requirements that already existed. So this guidance, all it really does is provide a helpful set of structure to make it easier for you as providers to actually adhere and translate some of this guidance. So one of the key bits of legal guidance that needs to be considered is the Work Health and Safety Act 2011. And what it means for you as providers is that the Act requires employers to eliminate or minimise risks to health and safety as far as is reasonably practicable. So COVID-19 is clearly a foreseeable risk, and so it's important that every service provider is doing what is reasonably practicable to mitigate those risks. And therefore, that means that each service provider is required to identify, assess, and minimise the risk of COVID-19 as much as is possible. It also makes it a general duty to consult with workers on all safety measures. So therefore, when we're doing that process of identifying, assessing, controlling, and indeed reviewing your control measures, you do need to be consulting with your staff during that process. So that then leads to an important question: what is reasonably practicable? And it refers to the highest level of protection in the circumstances to eliminate or minimise the hazard or risk. So what we'll talk about later in the document is the idea of the hierarchy of controls. And really the point about the hierarchy of controls is that there is essentially a list of hierarchical controls going from highest control measures that are most effective to the least. And the idea is that you basically systematically work through that hierarchy of controls. So the first is essentially eliminating the risk by conducting the service in a non-face-to-face setting. But clearly, you work in the real world, that's not appropriate or even possible for many of the services that you're delivering. And so therefore, you then work your way down the hierarchy of controls, and down towards the bottom, you've got things like use of PPE and things like that. So some of the other controls that essentially, if you can't do the most effective controls, you work your way down the hierarchy of controls to those things that you can do and those things that are reasonably practicable. So that kind of overall, I guess, philosophical approach is quite useful in helping you try and have the most robust controls that you can in a reasonably practicable way. And then it's also important, so Work Health and Safety Act is clearly a really primary piece of legislation here, but there's a range of other relevant bits of legislation that you need to be across, and that this guidance sort of synthesises and summarises some of the issues that relate, and that's around public health orders, and clearly there's a changing environment, anti-discrimination. So particularly this comes into play, as Alice will talk about later, around vaccinations and so on, privacy, industrial relations and workplace law. So those are some of the key legal requirements. And Alice is going to talk us through a bit later on some of the services that the Justice Connect can support and provide for any sort of specific legal issues relating to your context as well. So I'll hand back to Mika, and if you could talk us through this final piece of the management plan.
Yeah, sure. So this is somewhat reiterating what we've said already. That is the COVID-19 management plan. It's made up of these 3 plans, and again, if you have already put these plans in place, just be sure to review them to make sure they're up to date, that they fit in with the current legislation, that they fit with the risks that you see in your community at the time. And in addition to that, as part of the DCJ policy, there is the requirement on the right side that there are these processes in place for each of the service providers. So it's very likely that you already have some sort of a flow diagram or a chart that explains what to do in each of these situations. For example, what will you do to respond to a confirmed or suspected case of COVID-19 in the workplace? Or how do you support a client with a confirmed or suspected case of COVID-19? So just making sure that you have these at the ready and they have been communicated appropriately to the relevant workers and clients, so that if something should happen, everybody is on board and knows what they have to do next. So if you've got those in place, great. If you haven't, you need to start thinking about how you're going to put that down on paper. So on the next slide, this is just speaking briefly about the first of the plans, first of the 3 plans. So that is the COVID-19 management plan, or the COVID-19 safety plan. Sorry, the COVID-19 safety plan. So this is accessible on the New South Wales government website, and you've probably already done it. If you haven't, you need to go and do this. So you go onto the website, you select the industry that's most applicable to you, and you fill out the COVID-19 safety plan using this specific online template. And you also have to register as a COVID safe business. So this is really basic. Most of you will have this in place, and you just need to keep a copy of your plan available. And if someone asks for it, you need to present it to them as well. Okay, so I'll hand back to Jay for the risk assessment.
Lovely, thanks very much for that, Mika. So yeah, I think the risk assessment is something that it will obviously inform both the COVID safety plan and your business continuity plan. So it's probably sort of if you're in a situation where you perhaps have already got some existing plans in place, that you're dusting down your risk assessments. Once you've done that, you may want to just revisit either your COVID safety plan or your business continuity plan, because they really stem from the thinking that you're doing in your risk assessment plan. The risk assessment templates that's been developed, essentially what we've tried to do is build, stand on the shoulders of giants. So we've not tried to, I've said reinvent the wheel. Obviously this is a wheel, but we'll live with that for a moment. So the cycle of risk assessment is a well documented approach that will be well understood by all of you in this call, no doubt. But the key steps for it are, firstly, is to identify what are the hazards, what are the potential, so these are the hazards that would stem from the operating environments that you're working in and the range of operating environments that you're working in, the types of workers that you've got. And as Mika mentioned previously, that could be full-time staff, contractors, volunteers, students, etc. And then the clients that you've got working, that you're working with, so the range of different groups that you're working with. So once you've sort of thought through the different settings, operating environments, the workers and the clients that are working in those operating environments, you then need to assess the risks. The risk assessment process, as everyone knows, is a fairly well understood process of thinking about severity. So it's impact and likelihood, I should say, or sort of severity and likelihood. And that leads to a straightforward impact matrix where you essentially think about where you're essentially multiplying likelihood and severity, and that gives you an urgency to address the actual risk. So once you've got that essentially gives you a prioritized list of risks to then be addressing in your plans. We then think through what are the control measures that we're going to put in place. And again, in the guidance, we put through lots and lots of information based on the consultation about what some of those control measures look like. And that leads us then to the final part of the risk assessment cycle, is then making sure that we're reviewing and maintaining the controls and recognizing that you will be wanting to do this on a periodic basis in any case, but then there'll be certain key triggers that may cause you to want to reassess your risks. And that could be a change in public health order. It could be the fact that you've got a confirmed or suspected case, either in your region or in your one of your settings. So there's a few examples that could cause you to therefore have to kind of revisit this. So it's supposed to be a live business as usual type of process that we're talking about here. So if we move on to the next slide, I just wanted to talk through the first part of the cycle. So when we're actually identifying the hazards. And as I previously mentioned, we're thinking about the types of activities that you carry out, types of workers you've got, the clients that you work with, and the operating environments. So, and in terms of the activities, this would be all the tasks performed by a worker at a service setting. So it can be quite variable, and it needs to be cognizant of everything that they're doing, and both also in terms of travelling to and from or between different service settings. In terms of workers, so importantly, a person is considered a worker if the person carries out work whether or not it's paid. So it can be paid or unpaid in any capacity for the service provider. So it includes employees, contractors, subcontractors, consultants, volunteers, students, and students really in the broadest definition, so including apprentices, trainees, and those on work experience as well. So it's quite the worker definition is quite broad. And again, your clients are a broad group as well, which can include any individual group or young person to whom services or programs contracted by DCJ are made available. But it can also be broadened out to other groups as well. So it can include households, tenants, families, members of the public, people with a disability or offenders. All of these and more would be under that definition of clients. So I think some of the key things to think through are how do those different types of people interact with one another? Are there any known health and safety problems? And are there any risks that are shared with your suppliers and partners? And so we're very cognizant that in DCJ, in many instances, you might be sharing certain service settings with potentially like the council or with other social enterprises, or there's all sorts of interesting kind of shared operating environments. And so I guess that those need to be considered as part of your risk assessment template as well. So that hopefully, and again, lots more information in the guidance, we're just providing a summary here, but that's the hazards. So that's the first step, identify them. If we then move on to the assessment of risk, as I mentioned before, the very standard approach that hopefully you're familiar with is thinking through the severity and the likelihood of the risk, which constitutes the overall sort of mechanism that harm may come about. to the people that you're working in your service setting. And once you've rated those risks, then that leads you to an overall risk rating, which gives you a sense of the urgency of addressing these risks, ranging from immediate action through to something that may only need to be addressed later in the month. And so, an example would be an unvaccinated client who's exposed to COVID-19, who's a if they're one-to-one with a staff member and they forget to wear their PPE or have lack of training, and then the staff member either gets COVID-19 or becomes a close contact, that could be an example of a potential risk that you would need to then think through how you mitigate that and what you put in place to try and prevent that risk from becoming an issue. So I think that's the assessment process, the second step of the cycle. If we move on to the controls, so I kind of discussed this previously. It comes down to the hierarchy of controls. So the broad concept here is that you should always strive to the highest level of control possible that's reasonably practicable. And that's the issue here, is that because if we know that the highest level of control will have the highest level of protection and from a health and safety perspective, and it will also have the highest level of reliability in terms of actually mitigating a risk. So in an ideal world, if it was reasonably practicable, if you can deliver a service not in a face-to-face setting, that would be an example of how you could remove some of the hazards. We recognise that's not reasonably practicable in many instances. That's just not a practicable thing to do. It's just not going to work for many of your the clients and the situations that you're supporting. And we know that in DCJ services generally, you're working with some of the most vulnerable cohorts of people in the whole of the country. So you have to have that face-to-face contact. So then you basically said you work your way down the hierarchy of controls. So, and an example might be substitution, and that could be an isolation. So you could try and physically separate a hazard, such as using barriers. You might try and engineer processes. So that could be an example, could be, vaccination. Vaccination should always be considered as one of the highest, efficacy controls available. But also thinking through how air is recycled, ventilation, air conditioning. And again, sometimes you have control over this, sometimes it's not reasonably practicable for you to change that. But you should always consider these, first. But again, switching accommodation, so actually switching to single room accommodation, for example. And again, the conversations we're having this morning a lot were about shared settings and the challenges that can pose. But again, we all recognise that's not always possible. And then as you work down, you then get down to sort of less, protective measures, but that in some instances are going to be the most reasonably practicable. And that could be things like your QR code at check-in, donning PPE equipment, and so on. And again, in the guidance, we've given a lot more examples of this. But so that's really the steps to think through is always strive to the highest level of control you can, but then work your way down as you need to, based on the reasonable practicability of the service that you're delivering. And then the final point, if we think about the risk management cycle, is just really to make sure that we've thought through how we're going to be reviewing this process. So typically you'd have a regular governance process for reviewing your risks. And if you find that control is not working, that's a really good time to be reviewing your risk assessment. If you know there's some change in legislation, such a public health order that might have changed things, then again, you're going to want to review your risks and plans accordingly. If you're consulting with your staff and you're finding out that some of these controls aren't going to work, then again, you might need to review. And so what you're going to be thinking through is all of the information really on the right-hand side, which is how to make sure that your training, your information, your plant equipment, the overall health and safety approach that you've got is appropriate. So those are all the sorts of things that you need to be thinking about as you're working around your risk assessment process. So that's really the sort of the core of the cycle. And what we've done in the guidance is we've developed a really step-by-step methodical approach for you to work through that 4-step process. And so what you can see is on the risk assessment templates, so, and there's an Excel spreadsheet that we've put out in the guidance that you can fill in. And what we've really stepped out is the first 3 steps are about just helping you to identify those hazards. So we suggest that for each different service setting that's being delivered, you need to have a separate row on the spreadsheet, because the nature of risks fundamentally are quite different, whether it's a coffee van as opposed to a kind of an office setting, very different. So for each setting that you deliver, you need to have a separate, row on your Excel spreadsheet. Then think through the types of tasks that you're doing, how the service is delivered, who's delivering the service and who's receiving the service. And then from that, there's a set of risk factors. And again, in the guidance, through the consultation, we've gone through a number of those risk factors. And then that leads to that severity and likelihood matrix that we talked about previously, which helps you to then assess the urgency of addressing the different risks. Once you've got that prioritized list of risks, you can then think through the actual controls that are going to be reasonably practicable for your service, which will lead to an agreed action plan and then an approach for continually updating those risks. So that's, again, the flow charts that stems from the overall cycle. And I guess key thing to reiterate at this point is we're not asking you to do this from scratch. If you've already got risk assessments in place, if you've already got business continuity plans, if you've already got COVID safe plans in place, and you're confident that the risks are well managed and you've got good controls in place, that there is no new requirement for you to do additional work. However, we would hope that those of you that are looking to either refresh your plans or haven't yet had a chance to do some of these will find some of this guidance very helpful to you. Okay, so if we move on, so this is the third of the 3 aspects of the overall COVID management plan we discussed, which is the business continuity plan. And again, through our consultation, what we found is that each organisation uses some quite, and depending on the part of the type of service that you're delivering, there's a range of different business continuity plans, templates and approaches that are used. So we don't look to mandate any particular template for the COVID-19 management plan. What we have done in the guidance is just pointed you all to the New South Wales Small Business continuity plan, which talks about a range of risks that include COVID-19, but other disaster preparedness, sort of bushfires, floods, and so on, which we found to be a very useful plan. So I think we'll drop that, and if we'll ask you to drop that link into the chat as well, if for anyone wants to have a look at that. But again, we're not mandating any particular template. We are just trying to provide some guidance and point you towards an existing template that DCJ finds to be useful. Okay, we have consulted, as I mentioned previously, quite widely on this piece of work. So we've spoken to all of the peak bodies across DCJ who have supported really carefully with a range of resources. So recognising that you've all been managing COVID for the best part of 2 years already. So there's already a huge amounts of thought work, energy and effort that's already gone into this. And the peaks have been very proactive in already putting out guidance. So again, what we try to do is make this DCJ guidance something that kind of distills and synthesizes a lot of the good practice that's already out there. And so when you go on to the guidance that we've developed, which I think Sophie Michelle had very helpfully put a link to that in the chat. Again, for anyone that's not had a chance to look at it yet, you can have a quick look at it while we're on the call. And we've given links to all of this range of risk assessments, seminars, templates, and webinars that have been undertaken. So again, everything that we've put out in this guidance is consistent with what's been put out previously. Noting that this is a dynamic situation as well. DCJ is also looking to update this guidance on a periodic basis, because I think if one thing we've all learned in this space is it's a dynamic situation, and we all need to be quite fleet of foot. Okay, thanks, Mika. So I'm just going to hand over now to Alice. And Alice, if you could just talk us through Justice Connect's support that's available, that'd be wonderful.
No problem. So as you can see on the slide up there, we've got a range of different supports that we can provide to community organisations. I guess to start with, we've got some really good information on the website. We've got some free on-demand webinars about public health orders and introducing mandatory vaccination policies for staff. We've also got some answers to frequently asked questions. I'll pop the link to that in the chat in a moment. We're constantly updating these as new issues come up. Finally, we can provide free advice to not-for-profit organisations about implementing a COVID-19 management plan, including, legal questions that come up throughout that process. For example, obligations under workplace laws, privacy laws, anti-discrimination laws, and so on. So if your organisation needs advice, we do strongly recommend that you get in touch with us. In terms of our eligibility criteria, we prioritise helping small to medium-sized community organisations that are serving disadvantaged communities. So if that's you, and if you're struggling to come to grips with some legal issues, please feel free to approach us for some legal advice, and I will share a link about how you can do that in the chat.
Lovely. Thank you for that, Alice. Really appreciate that. Great. Okay, so we're just going to pause at this point and just see if we have any questions from people on the call. And so, if you feel free to pop a question into the chat function, or just to come off mute and ask the questions now.
I just had a question for Alice about accessibility. Is she inundated at the moment? Are we able to get to you before the 22nd
of December?
Yeah.
Look, we're prepared for an increase in inquiries because of the introduction of this policy. So, look, we're here. We're doing our best to respond to inquiries as quickly as we can.
All right. Thanks so much.
No problem, Steph.
Lovely. Any other questions for people on what's been discussed on the process, or any other aspect of the guidance presented? Okay, and Alice, thanks ever so much for putting some of those links up. So I'm just going to talk a little bit about some of the considerations and the controls for workers and clients. And as I was mentioning earlier, if we think about staff, so both, you might have paid staff, and that could be staff that are employees or contractors, and sometimes, possibly paid volunteers, or unpaid staff. And again, those could be students and volunteers. And then you've got your clients. Some of the risk factors that you need to consider are, the types of activities. Vaccination status is clearly, and Alice will talk a bit more about that in a little while, but that's clearly one of the big risk factors, is whether or the proportion of people in your facility or your service settings that are vaccinated, whether that's clients or workers. And clearly the broader environmental context around what the level of transmission of COVID-19 is. And again, as we're seeing more and more opening up happening across New South Wales and across the country more broadly, obviously that's going to have an impact, which again links to issues around whether or not staff or clients are attending multiple locations. And so, I think we had a call exclusively focused on domestic and family violence this morning. And that was certainly an issue that was discussed about if QR codes hadn't been routinely used. That was one of the things that was delaying. Actually, I should mention a really good tip came up on this morning's call around around contacts, or whether you can become a contact of someone else, is that on the New South Wales Service app that we all use for our COVID check-ins when we're going into facilities, that is actually where you will find out a notification. So often, as numbers are getting large, sometimes the contact tracers won't necessarily reach out and get in touch with you directly, but you may actually find out on your COVID Safe app. So it's worth going in there and having a look to see, and that's something that you can inform staff and clients in the premises that's another route where they might actually find out whether they've been a registered contact with somebody who's got COVID-19. So so we're trying to share as many of these insights that are coming out through these discussions. So look, the other thing to think about here in some of these considerations is that you need to consider the workers' regular tasks under Fair Work Australia's 4 COVID-19 risk tiers. So that's a really important thing to think through. So tier 1 is people that are interacting. Tier 1 work is defined as interactions with people with an increased risk of being infected with coronavirus. So that would include employees working in hotel quarantine or border control. Tier 2 is close contact with people who are particularly vulnerable to the health impacts of coronavirus. So that could include employees working in healthcare or aged care. Tier 3 is interaction or likely interaction between employees and other people, such as customers, other employees, or the public in the normal course of employment. So that could include providing essential goods and services. And then tier 4 is where you have minimal face-to-face interaction, and that could be, an example would be working from home. So the level of the tier that you're delivering your services, within which you're delivering your services, is a key consideration to some of the controls that you might need to put in place. And just going back to the vaccination point, vaccination status is one of the key risk factors. The next one is another thing to mention is populations and how vulnerable the populations are. So whether you've got people with more chronic diseases, high risk factors, or potentially people who have, who are potentially immunocompromised. Okay, so if you just move on to some of the specific issues. So when we're thinking about homelessness services and domestic and family violence residential services, so there's a range of issues that came out through our consultation, and we'll go into a bit of an interactive discussion in a minute, because we'd love to hear some of your experiences delivering services, about some of the challenges that you faced. But we know that sometimes you may be facing hesitation towards vaccination, and that could potentially be from clients or some of your workers as well. In some instances, you might be experiencing people with lower socioeconomic status, who potentially health literacy levels may not be fantastic. And there's going to be a whole range of other considerations. So again, just thinking through to the discussion we had this morning, there was some understandable concern from some clients that actually they almost, I think there's one example of someone who mentioned that there was one client who'd actually rather stay homeless than going into a shared environment where they were going to be in close proximity with other people. So there are some of these kind of nuanced, considerations for the people working in your environments. Now, we say this knowing that essentially you are all the experts of this, because this is the space that you've delivered for a long time. But we just thought we'd put this slide up as a bit of a thought starter, really, for a bit of a conversation. So perhaps if we go to the next slide, so we really wanted just to open a bit of a conversation with you and get some of the shared reflections from those of you who are delivering these services. So you've obviously been, already having to deal with these issues for the best part of 2 years. So just keen to hear from you what some of the top risks that you are for the workers and clients in your services, and what controls you found to be most effective. So I'll just put that out to the group, really open the discussion up. And of course, we've got a range of the team available here to ask any questions at this point as well. So what love to hear from people what your key risks are, or some of the key challenges that you faced. Okay, so thanks, Kate, for getting the ball rolling. So residential services with shared facilities are the highest concern. Absolutely, yes. As was alluded to on this morning's call, that's clearly, and residents with health vulnerabilities. Yeah, that's really good. So, Kate, I might just ask you to just expand a bit on that point. If you could just talk a little bit about some of the experiences that you've had. Kate, if you're able to come off mute. Okay, I'm not sure Kate's able to come off mute. And then Cara, you were talking about residents with health vulnerabilities. So again, would love just to hear a little bit more from you about some of the health vulnerabilities that in particular.
Yeah, sure. I'm from the same organisation as Kate, and back at the beginning of the pandemic, we did an assessment on the health of the residents in our shared congregate facility, and our residents had lots of different health vulnerabilities, as well as aspects of their current presentation, which meant they'd find it very hard to not only understand but adhere to the health advice and the different recommendations being made around social and physical distancing. So we did do this assessment a while ago. And I guess those vulnerabilities were to do with both mental health, physical health, immunity, pre-existing health conditions, acquired brain injuries. Yeah.
And it'd be interesting because what kind of controls have you or mitigations have you been able to put in? Because that's obviously incredibly challenging when you've got those range of challenges with your clients.
Yeah, well, our decision back then was to move current residents out of that shared care facility, and now we're looking at how to open it back up safely. So that's the position we're in at the moment. Unfortunately, the physical layout of the house means that social and physical distancing isn't possible. We've got shared bathrooms, shared kitchen, shared lounge room, shared hallways. It would just be impossible to maintain that distance between residents and staff. So our highest control is obviously vaccine. But
lovely. Thank you for that, Cara. And absolutely, vaccines. It's a good reminder. That's always one of the highest controls that can be in place if possible. Nav, I see you've said that clients are not disclosing symptoms in a residential setting. Again, perhaps you could just talk a bit more about that, because that issue came up this morning as well.
I think for us, because we're a domestic and family violence specialist service, we obviously ask clients the key health questions when we bring them into the refuge, or if we're doing a phone assessment. But the reality is that the clients may not disclose some symptoms that aren't picked up that could potentially be COVID-19. Obviously coughing and sneezing and things like that, and temperature, but staff aren't there 24/7. They're not there over the weekend. And the other issue is a client telling other clients that they're COVID positive when actually fact they weren't. And that client had a particular mental health issue at the time, and the fear and the panic that went through everyone, I guess, and knowing our rights, as in we don't have, I guess my understanding is we don't have the right to ask their health background in terms they can offer their vaccination status, but I'm still not sure where we stand in asking for that vaccination status to be declared, and obviously people are choosing for whatever reason not to be vaccinated, we've still got a duty of care my understanding of our contracts, that we still have to provide some service. And this is all in a rural area, not in the cities, where our ability to have outsourced venues to put people, if they are tested positive, there's a lot more, I think, restrictions perhaps around that. I know that's a lot of things in the one question, but they lead into one another, if that makes sense.
Yeah, no, thank you for that, Nav. No, that's really interesting. And I think I'd love Alice to sort of get your perspective on this, both in terms of because there's quite a lot in that question about some people not disclosing it, some people inappropriately disclosing it, and whether or not we are in fact able to ask people what the status is. So lots going on in that question, Alice.
Absolutely, happy to talk to that, because those are questions that so many people are asking. You're right to be thinking about privacy, because a person's vaccination status is their private health information. So that's a special kind of information that attracts quite strict protections under privacy law. So basically, an organisation can collect health information from someone, but only if it's reasonably necessary for the organisation's functions and activities, and you have consent from the client. So when you're thinking about whether it's reasonably necessary to collect health information, basically you're thinking, is it necessary to know if someone's vaccinated for the purpose of complying with our health and safety obligations and providing a safe service? And if you think it is necessary to know, then under privacy law you can ask, but of course you do need the person's consent. So you can't force a client to tell you if they're vaccinated or not. If you have a policy of asking all of your clients if they're vaccinated for health and safety reasons, and someone decides not to answer or give that information, you might decide that, okay, anyone that doesn't provide an answer we treat as unvaccinated, so that we can manage risks around that. So that's the law around privacy and asking clients for that information.
Thanks, Alice.
Yeah, thank you for that, Alice. That's really, really helpful. And Kelly Wyatt's got a question. So if we need to support a client in our shared accommodation space with isolating, etc., there are limited places we can place them, external accommodation, especially if they're not vaccinated. So yeah, Kelly, perhaps if you could just expand on that point a little.
So our women's refuge, we're a shared accommodation space. So even though the women have their own bedrooms, if they're awaiting a COVID result, for example, there's limited options that we can utilise in terms of making sure that they can abide by those isolation rules. One thing that we've found is that looking at accommodation options, I'm in Port Macquarie, so we're a rural area, limited accommodation options as it is. However, we've been faced with a lot of issues around motels and hotels asking about vaccination statuses of the people we're trying to book in, and if they aren't vaccinated, then we haven't been able to book them into external accommodation. So it's that issue of, we can't move them out of the refuge for the sake of isolating them. However, that's part of our plan, is to make sure that we're not putting other women at risk in the house while we're waiting for that result. So it's a bit of a tricky limbo space unless we can get them into a place that's not asking about those records, I guess.
Yeah, that's a bit of a catch-22, sort of probably finding yourself there. Alice, I'm not really sure there's any legal, this is more of a practical issue, isn't it? Yeah. I think that's it's just a supply and demand issue, really, of trying to find people that are willing to not ask that status, really. So yeah, I'm not sure if I've got a huge insights. Unless
is there a way that we as a service can advocate to make sure that there is a space, whether it be through a service like community housing or linked to home or something like that? Is there a way that we can advocate to make sure that this woman isn't put at risk or putting other women at risk in the same space if we can't find that from ourselves as a service? is there a way that we can advocate with a different organisation to try and make sure that that doesn't happen?
So I'd love to hear from DCJ, your perspectives on this. Perhaps I might start, Michelle, if you could. I know you've got a few other people from the area, in your area, on the call as well.
I think this is one, if I can throw to a program person, that this might be a question that they'll have some more knowledge on. Deanne, are you online? Are you able to assist?
Yes, I am. I'm here. I'm hoping you can see and hear me.
Yeah, we can.
Hi, Kelly. Hi. I have spoken with someone else recently from a regional area, so I'm not sure whether it's the same patch, but from my understanding, there in this particular area there was limited or no health accommodation to support people that might have been COVID positive, and that might be similar, although it sounds like to me for this individual you're not sure whether they're positive or not. We have, and you'd probably be aware of this, I'm sure, the emergency accommodation, you know, the funding that you can apply for to put someone up, but then what I'm hearing from you is the blockage seems to be with the hotel or motel owners, and they are obviously private entities. We don't have any jurisdiction over that, so it is a bit of a wicked issue, and unfortunately I don't have a silver bullet, but I am wondering if there would be other people online from other regional areas that might have had a similar instance, and it's about you know, whether the wisdom of the crowd can also help us to try and answer that. I don't have, as I said, a silver bullet here around how to manage that. It's through partnerships, I think, and relationships with, you know, maybe your community housing provider might have great, you know, some relationships with some of those TA providers and so on in the area, and you could leverage off that and build that relationship and speak with them about how to manage the situation. So I'm afraid I'm probably not throwing up anything of in terms of particular solution. Is this like a live issue, Kelly, for you? And obviously you haven't experienced it before.
No, so we did have a client that we went through that process with. Thankfully, she was vaccinated, so we were able to organise something in that space. However, we've had quite a few women accessing our services. Our refuge is full, and we've got a wait list that have been utilising all of their TA. And you know, it's been the conversation that if we do have to go through that process, if any of the women in the house have utilised all of their TA, and we do have to find external accommodation options for them, that we've just been having that issue with a lot of the motels if we've been attempting to book people in. So we're just conscious of the fact that we're going to have to navigate not only someone who could potentially be COVID positive, but also trying to find them a safe space that they can go to so that we're not leaving them with nowhere to go. So it hasn't specifically happened yet. However, we're aware that now with New South Wales opening up the way it is, accommodation in Port Macquarie is next to impossible to find as it is. So
yes, well that's another issue, isn't it? So it's part of your risk assessment really that you're trying to understand, you know, this scenario a bit better.
Can I just jump in here, Deanne, and ask Kelly, in terms of kind of like communication around vaccination, does your service communicate the benefits to your clients of vaccination or encourage vaccination?
Yeah, we do. And we've had partnerships with different local services that have been providing those vaccinations for our clients. So we've been able to support clients with accessing that. However, for clients to access our services, it's not, you know, we're not asking them about their vaccination status or anything like that. We're just providing them with the information of where they can get that info or guidance. So, you know, when women are coming into the refuge at the moment, we are asking them if they're comfortable to disclose their status for our purposes of making sure that we're you know, providing the right supports for them, and especially with different health conditions and things that, you know, we might not have asked certain questions before. So we're making sure that we ask those questions now if they're comfortable to answer it, so that we can make sure within our plan that we're looking after them in that space. So, you know, it's not a requirement for our clients, but it is something that we have been talking to them about.
Jay, there's it looks like some information in the chat. I'm not across all of that.
Yeah, I'm across it. So I'll just summarise, and okay. I'll come back to Liz, who made a really good point on a different thread. We'll come back to that in a second. So I think SSH, I'm not sure who that is. I think it's on the DCJ side, had said, I wanted to ask if anyone else is having challenges around managing residents, bringing guests over and being allowed to come over to residential settings. We have some houses which are fully vaccinated, young people and staff, and some houses which do not. We also have changes with residents moving in and out of the service, so constant changing vaccination status, or organisations having different risks plans per houses or blanket restrictions. So I guess that's just a few questions that are being posed for people to think about. In the meanwhile, you're chewing on that, Carolyn and Caroline have both made a couple of comments. So there's no Department of Health COVID accommodation and COVID hotels in most rural areas. So in other webinars, Sydney Services have said their residents were moved to DH COVID accommodation. This isn't available in the majority of places. So the problem is that hotel and motel owners will often, typically not take close contacts, let alone COVID positive clients who have mild symptoms. So in our area, there's only one TA provider and it's used by all services and fills really quickly. And then Caroline's pointed out, I know we aren't speaking of the housing crisis, but most organisations along the coast are about to hit tourist season. So this issue, or this control, I guess, is going to be even harder to put in place. So accommodation's already booking out for the season. And Rebecca said that, yeah, we have the same issues. Isolation for a single woman in crisis accommodation is a little easier, but if it's a woman with children, not so much. Nav's pointed out a drastic option for rural and remote DFE is to not take on any new clients at the time of testing until it comes back negative. And, you know, Carolyn, we're having conversations with women about who will care for their children if they get COVID and are too sick to care for the children. It's a hard conversation for DFE clients who are not vaccinated. However, it's a real problem. So yeah, thank you for sharing that, because yeah, that's clearly hugely challenging. But the whole point of a risk assessment is to try and preempt some of these issues before they happen, so that we can kind of think through what some potential solutions, or options that could exist. So yeah, does anyone else have any? There's a lot in all of those comments. Any other sort of reflections from anyone about from DCJ side in response to any of that? Okay, so then I'll just take us back to there's another thread. Sorry, is there someone coming off to make a comment there? Thought I heard someone coming off. No. Okay.
Sorry, were you asking for DCJ?
Yeah.
I don't want to leave you in the lurch there. I didn't have a magic bullet, but I was actually madly making some notes around, obviously what I can see, and I'm sure others can see, is the escalation of an issue there around TA in coastal facilities and in an environment where we may have increased COVID cases, so just putting more pressure. As I said, I don't know that there's a silver bullet, because I'm sure we would have communicated on it if there had been one. We would have shot that off, but
it looks like we might need to take that one away, because it sounds, particularly as we're moving into summer, and as has been pointed out, this issue is only going to escalate as there's less and less temporary accommodation available. It sounds like that mimight be one that we need to take away and give some thought.
Yes, but thank you. Thanks, Kelly, and others that have raised that. Thank you. It's good. It's really helpful information.
Yeah, thank you, everyone. That's really good. And just returning to a really good point that Liz Yo had made, which is one of our concerns was being inundated with people needing support when we opened the physical doors to our info and referral service. We opted to put in place a COVID marshal, which has worked really well. So again, Liz, if you're able to sort of maybe just share some of your insights, because that sounds like a really good solution, good practical solution that you put in place there.
Oh, hi, Jay.
Hi, Liz.
Hi. Yeah, just probably a couple of points I'd make about it. One is it was only possible really because we were lucky enough to get some of the additional COVID money. So that meant we felt like we could spend some money on something that would add to the safety element. So that was really helpful, that funding from DCJ. Secondly, obviously, with any role like that, it has to be the right kind of person who's going to be the right person to engage initially with clients, many of whom were not vaccinated. So we didn't have the marshal there to be like a police security kind of approach. It was more taking some of the stress off the staff, with them knowing someone else was worrying about how people were checked in, that there was a mask available for them to wear if they didn't have one. That they'd done the hand sanitizing. It just helped to relieve some of the anxiety for staff about not only could I have a whole lot of people I've got to assist her in crisis, but we might be overwhelmed, and it just helped pace things for them with that initial sort of screening line. Plus, the other strategy we used with that was important was helping clients or prospective clients who didn't know how to access their vaccine status on phones or whatever, how they could do that. So a bit of an education around this is how you can, get your status and show it to people has been quite important too. So yeah, but just on a completely different note, I just want to acknowledge too what all our, when I'm not in a region, but what all our regional colleagues are facing. I just really want to acknowledge that it's incredibly tough, obviously, on the housing front out there. So.
Yeah, thank you for that, Liz. No, thanks for sharing those insights. And yeah, on that, really good points made by Gillian on that same topic around some of the challenges in rural regional areas. As Gillian was saying, rural and regional are highly challenged, not just coastal, and as well there are some religion-based barriers amongst northern New South Wales. So again, Gillian, would be great if you could perhaps expand on that point a little. If you're able to come off mute. But
hi.
Hi, Gillian.
Hi. Yes. So we're in northern New South Wales, so there's no accommodation anyway. So it is difficult. But in our communities, we also have some religious groups that have another reason for not being pro-vaccination. So we just, I was interested though, is where do we legally stand when we ask somebody if they will have a COVID test?
So, Alice, love it if you could give your reflections on this.
Yeah, it's an interesting question. So whether you can ask someone if they are willing to have a COVID test?
Yes.
I mean, I guess it's not really the same as asking for someone's health information. Rather, you're sort of asking them to do something as a sort of eligibility requirement for receiving your service. I suppose, I'm not sure if the same privacy considerations would come about in terms of limiting whether you can ask someone to have a COVID test. Certainly once you received the results of that COVID test, you'd have to treat it carefully as private health information and store that securely.
Alice, is it? Do you want to? Is that one you want to maybe come back? Is that something that we could come back to after the call?
Yeah. Let me have a think about it.
Yeah,
it's a good question.
Yeah. No, that one's not come up before actually. So, Gillian, thank you for that. This is really good. So we'll take that one away. We'll also take the other issue that was discussed previously about the temporary accommodation challenges and how that might be resolved as well. Kelly was sort of saying before coming into shared accommodation, maybe, as in, Kelly, could you just expand on that point? I'm not quite sure. I think I know what you mean. Regarding the COVID test, yeah, thanks. Yeah, so it could be something. So is the question? I think the same question would still apply. Then is could you ask someone to have done a COVID test before coming into shared accommodation? So again, yeah, I think that fits into the same category. So we'll get Alice to come back on that. Okay, good. All right. Well, I wanted to move on to another question now, which is about the new normal. So if we move on to the next slide, actually, because we're conscious running at 15 minutes left. So we're just conscious that as we're moving towards living with COVID-19, and that's got a number of manifestations to it. So we're seeing overall higher vaccination rates, but recognising that there is a small percentage of people who are vaccine hesitant. It's also seeing more borders opening up nationally and internationally. So there's actually going to be more COVID flowing around our communities. And it's so I think one of the things that we've generally seen when we see opening up of borders is that you tend to have more localized kind of outbreaks happening. So we're feeling, overall view, I guess, looking over the next 6 to 12 months, is that we are going to see, hotspots, and particularly given that we haven't got down to vaccinating, a very high rate from 12 plus, and it hasn't been regulated from 5 plus, and then lower levels. What the health kind of expectation is that overall that you will go down to infants, and this will ultimately, the COVID vaccines will end up in the childhood vaccination schedules. And also we're expecting that booster shots will become almost a part of the schedule, because of what the research is showing is that it's really only after the third vaccine is actually having really quite a significant impact on overall levels. So just as an aside, those of you that have had 2 vaccinations, I would definitely encourage you to get a third vaccine. And it may even be that it then needs to be done on a more regular basis. So in that context, the question is, how might your controls change for your organisation? And I can see Steph's already come out of the blocks with so we include, I think Steph was referring to the previous conversation about the COVID test. So we include, and I'm assuming it's COVID testing, in our intake assessment, informing clients we are a pro-COVID-19 service to provide the best support for all. We ask people to be tested in the first 24 hours, moving to antigen testing, which is interesting and positive, and ask that if at any time they present with symptoms, they are open to be tested. If they decide not to, we refer them to a service that better suits their needs. Steph, would love to, just hear how that's gone for you, that approach.
We found it to be pretty positive, actually. So we had a couple of we're a shared facility. We had a couple of COVID positives along last COVID. And so we were very challenged about how to navigate through this. Our ultimate plan was that everybody be tested before they come into service, but of course that's not achievable. So the best next step for us was asking everybody on the phone assessment and the intake assessment if they're open to be tested in the first 24 hours. I actually haven't had anybody say no. Most people are very open to be tested. If not, we're happy to make the referrals to other services that kind of meets their needs. We're looking at moving into antigen testing at the moment. We're just putting the policies around that. We've got all the antigen tests. We've got some ambulance services and that in place now, about to show us how to use antigen. Well, we're not going to use them. The client will be using, so how to observe them. And then we'll be looking at using antigen testing for our clients on arrival. And again, we use the language, we're a pro-COVID-19 service. And so, if they're happy, if clients aren't open to this approach, but and we will make the appropriate referrals for them. So, yeah, so far so good. We've had some really good outcomes. 2 of our COVID positive cases we had were asymptomatic, so no symptoms. So we wouldn't have known, and it would have riddled our service completely. Had we not had them tested in the first 24 hours, it probably would have shut us down for a longer period of time. We found that we were able to shut down at that point for the 14 days as recommended. Public Health came in, they moved the client, fortunately we're in Sydney, so they moved the positive client to the health facility. Public Health came in, tested all our clients. We isolated everyone that was a close contact for 14 days. And so moving forward, we find this to be a positive risk assessed approach to it. Unfortunately, there may be some clients that we won't be able to support, but there are a number of services out there that will be able to meet those needs. So I think we'll be able to refer appropriately. Yeah.
Yeah, thank you for sharing that, Steph. And Alice, love to hear your reflections on that.
Yeah, I think that's been really useful to hear your experience with that. And on further reflection, really, I think asking clients to have a COVID test is kind of similar to asking people to sanitize their hands or wear a face mask on entry. It's one of those things that you ask people to do as a precursor to receiving your service. So organisations under the law have the right to I suppose, refuse entry or to put conditions on entry for, people who come into the workplace or receive a service. So requiring people to do a test, I suppose, is really a health and safety measure. And it's a question of, is that a reasonably practical control measure to adopt? And it sounds like it's been really successful in your organisation, Steph, for managing risks of COVID transmission in the workplace and nipping things early in the bud. Nipping things in the bud early. So thanks for sharing that.
Yeah, thanks, Steph. There's been a couple of follow-up questions to that. So Kate Timmons asked, sounds like you've done a great job. Would you be willing to share the wording of that on your intake form with Kate?
Sure, no problems. I'll grab it and put it in the chat.
All right. Oh, thank you for that, Steph. Yeah, that'd be fantastic. And if you're not able to do it in time, we've got a ability to email everyone on the group, so we could or whoever's interested. And Caroline Burgess is asking, do the clients have to isolate whilst waiting for their results?
So this is challenging. We're a shared facility, and so fortunately we have the way our building's set up is we have one bathroom we've been able to isolate and one room. But when I say they isolate, they still wander around, they still have to access the kitchen and everything. So we try to limit contact. But essentially, once they're in the building, if they test positive, they'll shut us down anyway. So we just limit the movement as much as possible so that they're social distancing, not accessing the same bathrooms, all that kind of stuff. So, but as soon as if they're positive, it won't matter. Public health will shut us down. Yeah.
And this is creating a lot of interest, this the thread coming here. So Karen was saying the approach, Steph, sounds good, but how would it work if there are no other services to refer to? And so I guess you're in Sydney, Steph, you've probably got other services. I guess in a rural remote area, it might be a bit more challenging to adopt that kind of policy. Yeah,
correct. We're very fortunate to have lots of options available to us for referral pathways. So yeah, so recognising that's a live challenge. A couple more questions. So hi Steph, just wondering how you've managed the medical supervision requirements of rapid antigen testing. Yeah, so we're still navigating this. So I don't completely know the answers. We're in the middle of putting our policies together. We've gotten linked. Fortunately, we have some high-ranking ambulance members, so we're working very closely with them. And we built a really good relationship with public health in our last COVID positive. So we're having some conversations with some workers from there, trying to put this all together. I'm not clear on that answer at this point. So there's home antigen testings, I'm assuming, but we'll need to get the legalities around this. We will not administer a test. We would just be present as a test was administered, and they would need to administer it and do everything that is required themselves. So I think that's going to create, same as medication, I think we'll kind of rank it similarly. This is my assumption. I think we'll rank it similarly as we never administer medication, but at times may observe medication. So I imagine that's probably where we'll head, but I don't have the answers at this point, sorry.
No, and I just wondered if perhaps if Michelle or Sophie, I know rapid antigen testing is a live discussion at the minute, and perhaps if there's just any, if you give an update of where that discussion is at the moment.
It certainly is a live discussion, and we meet regularly with the peak organisations, a number of peaks that represent providers across all of the DCJ services, and it is an issue that's come up there with peak seeking advice on how services might use it. It's actually something that DCJ is looking at for our own staff and our own workplaces. There is talk about a possible pilot being stood up to look at sort of all of the issues associated with rapid antigen testing. But I actually don't have any further details than that at the moment. But we realise that there are a number of services that are looking into it and are wanting some advice. So we're talking to New South Wales Health. We know that there's a pilot running in the Department of Education in schools. So we'll also be linking in with that to find out what they're doing and what they've learned about it as well. So when we've got more information about it, we can certainly get that out to you.
And what I can certainly share just from a general health perspective and everything I've read about the research on rapid antigen testing is that the where it's good is it's good if you're able to test people on a reasonably regular basis. Because the problem with it is it's not as accurate. Right? The fundamental problem with rapid antigen testing is, yes, it's convenient, it can be quite cheap, it can be done quite quickly, but it doesn't have quite the same accuracy as PCR. So for PCR tests, if you've got a small number of people that you want to test, the gold standard is PCR testing. But where rapid antigen testing can be useful is more in a sort of, if you're trying to mop up. So if for example you moved into a situation where you had an outbreak in a particular region and you were worried about COVID coming in, and you're looking at almost proactively thinking about how you could try and see if COVID was coming into a facility, that's where rapid antigen testing would be quite well suited for it. So if you're kind of like proactively trying to track and trace, but if you're reactively trying to address an outbreak of test contacts, PCR will be the way to go. Because it's all about the likelihood of someone actually. So it's more of a kind of like a proactive type of approach. So that's all I can say from the health perspective. A couple other comments. We're nearly out of time, but this has been a really rich discussion. And Kate has sent an email, but we'll make sure Kate and Steph get in touch with one another. The next question was working in the DFE service. We work with clients who can often contact our service in the pointy end of crisis. It's important for us to support them as soon as possible to ensure their safety. So it may be hard to request testing prior to supporting them. And then the question is actually, how have you navigated this, Steph? But I just wonder whether, again, Michelle, you might just want to make a comment on that before we go to Steph.
Sorry, Jay, can you just repeat that one for me?
The key question is, given that people are coming into DFE service maybe at the pointy end of crisis, it's important that we support them as soon as possible. So it may be hard to request testing prior to supporting them.
Yeah.
I just know in terms of our previous discussions about trying to be inclusive, whether you had any comment you might want to make on that.
Yeah, and look, that's really tough. That they're tricky issues to deal with. I guess in that situation when you are trying to provide an urgent or emergency service in particular, and you don't have time for testing, or to ask about vaccination status, then it's about putting in place your other controls around probably treating that person as if they are COVID positive when you don't know the information, or they might be likely to be. And so that's where you need to kind of implement other controls in your hierarchy of controls to safely address that risk until you've got an opportunity to either ask them to be tested or ascertain vaccination status.
Yeah, lovely.
But it's not an easy situation when you're dealing with those urgent and crisis services.
Yeah, absolutely. And I'm just conscious of time. We're nearly out of time. And then NAV had suggested services employ part-time health professionals on site to observe and guide the testing. So I thought that was just another interesting. And again, I think some of these controls, as and when the likelihood, the risk, the likelihood of the risk actually happening, I think you can then start to think about some of these additional things you might put in place. Conscious we're out of time, I just wanted to say what a fantastic conversation we've had. Thank you, everyone. It's been really rich, really lively discussion. Lots of really interesting to hear how different people have been responding to this. We hope you found this a useful session. Before we sign off, I'd just like to say a huge thank you from my team, so Mika and Anna, from Justice Connect. Alice, thank you for your gems of insights as ever. And then for the DCJ team, so Michelle, Sophie, Deanne, again, thank you for all the points that you've made, and Cassandra and Inara as well. So Michelle, I might ask you to say a few final words before we wrap the session up.
Thanks, Jay. I'd just like to say thank you, Jay, and your team, and Alice, for being here today and running this session. I hope you've all found it really useful. There's some really interesting questions that you've raised. There are some tricky issues that you're dealing with in this space, and it's ever changing. If you, Deanne and I have been having a bit of a chat offline about some of the issues you've raised and how we can raise them within the appropriate places within DCJ. So we will go away and do that. If there's further questions that you've got, please drop us an email at partner support or directly to me. And Deanne, I think, has probably got an inbox as well.
Yeah, the SHS program mailbox. Thank you.
Thanks, Deanne. But thank you very much. It's been a great session. Appreciate your participation.
Yeah, thank you everyone it's been really good level of discussion and questions, and thank you everybody who's contributed. And for sharing all your experiences. Take care everyone, have a great day.